In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance.
Pleasant good night and welcome to another HealthWise by the St. Kitts Nevis Medical and Dental Association. As usual, we are sincerely grateful that you have decided to spend your Monday night with us. Our motto, working towards healthier societies. Hence, we use this platform to educate, to raise medical consciousness of the people of this federation, which is a fundamental tool in taking control of one's health. We also use this platform to develop positive attitudes towards your health, thus improving the quality of life. Most importantly for me is that we use this platform to bring visibility to the soldiers of the health system, both present and past, whose sterling performances are the pillars of the health system. Before we get into our topic tonight, I want to send a shout out to Alice Pemberton, one of my patients, who sit anxiously every Monday night waiting for our show and who has informed me that she has learned a lot. Alice, and like many others, we thank you so much for tuning in. And we do appreciate it, and we do see you, and we do give you a big hug from the association. Also, as a matter of housekeeping, we would like to recognize Down Syndrome Day, which is always celebrated on March 21st. And at this juncture, I would love to give a big warm thank you from our association to the teachers of the Cotton Thomas School for providing a safe haven for our children who were born with this genetic defect. Your hard work and dedication have not gone unnoticed. Tonight, our topic is, and in our local parlance, letting my hernia ripe. That's something I've been hearing from since I was a child, and it has always puzzled me. In studio tonight, I have to discuss this lovely topic is Dr. Lawrence Rollins, General Surgeon, who has worked in the Federation since 1982 in both a private and public capacity. He's also a fellow of the American College of Surgeons, and I was afforded the opportunity to work with him in 2005. I must say I admired his meticulousness, not rushing, respecting surgical principles, and his willingness to impart knowledge. Dr. Rollins, thank you for being here with us. On my left, I have Dr. Jensen Morton, District Medical Officer that stretches, or he serves the community from Sandy Point to Challengers. He's also on-call doctor at the Poxon Medical Center, and he further serves his people in private capacity at his private office located at St. Paul's. Letting my hernia ripe. Something that we have heard, something we ourselves, that terminology we have used. Sometimes we actually even let our patients go along with the ideology of having your hernia or letting your hernia ripe. Before we get into the discussion, we would have to look at what is a hernia. We would also have to look at the parts of a hernia, and then we can understand if it makes sense to allow our hernia to ripe, or we should do something before it becomes ripe. So we're going to start out with Dr. Morton, and we're going to look at what is a hernia.
So when we are discussing anything that we call a hernia, it's a condition of the body in which we are having a protrusion of essentially one part of the body into an area where it's not supposed to be. That's the simplest way to explain it. So your body has different compartments within it in which certain things are supposed to be in certain areas. And whenever anything pokes out or bulges or wants to go into an area where it's not supposed to go, that essentially is a hernia. And in different ways that can be dangerous, but that in its essence is a hernia.
In essence, what we are speaking about is a hernia is basically a hole. Mm-hmm. And in the medical terminology, we would say a defect in the abdominal wall. Because what we are doing abdominal wall hernias, because we also have to highlight that we have different types of hernias, yes, but we are just dealing with the abdominal wall hernias. So it's a defect. And what we have to also notice too, sometimes when we speak about the abdominal wall, we just think about the in front, the part that is in front. Mm-hmm. But you have to remember that the abdomen, it's a cylinder, it has a front, it has a back. So wherever you can have a hole on this part of the body, then we refer to it as a hernia. Mm-hmm. Dr. Wallins, you would want to chime in because I know you have a wide range of experience as it relates to abdominal wall hernias, and to give your inputs as it relates to the definition of an abdominal wall hernia.
Basically, the defects, as we call them, are weakened areas. So the strength in the wall has gone, so that there is a protrusion of a viscus. A viscus is an organ or part of an organ which comes through that weakened area and can cause serious medical problems when unattended. Okay, like everything else, I'm not very happy with the term ripe, because it connotes a different kind of a different connotation. I would like in surgery, all our procedures that we do, we have indications or reasons why we do a procedure. And sometimes it's maybe elective, urgent, and sometimes it's an emergency. And many times a hernia can present as elective, or it can be urgent, or it can be emergency, particularly if it's going to potential to cause significant problems. Mm-hmm. So therefore, I'm not too happy with the term, but it's a colloquial term which has been around for quite a long time.
Well, I grew up hearing about that term, letting persons would ask, is your hernia, is it ripe as yet? Yeah, or they would say, my hernia is not ripe as yet, so I'm not going to go to the doctor. And growing up as a child, I always wondered, how do you ripen a hernia? I mean, it's not a mango, it's not a banana. So I don't know if you wrap it up in a brown paper bag as we do, put it aside and get it ripened. So it always puzzled me. When I became a surgeon, then I understood what it meant to, in the local parlance, to ripen your hernia. I had an experience where I was sitting in the OR about 11 p.m. going to do a hernia, And the patient said to me, Dr. Woodley, because this is an emergency now, and he said to me, my hernia is ripe. So then I figured, okay, when you have a ripe hernia, basically when we have complications. So that is why we need to eradicate that ideology, not just from the local public, but even sometimes in our colleagues, where we would tell our patients, the hernia is not ready yet. It is not ripe yet. And as we go along in our discussion, we would realize that saying those terms, it is not ripe yet, we are actually creating a problem.
I certainly agree with that. In that you don't want to wait until it becomes an urgent problem and give rise to possible complications.
Mm-hmm.
So therefore, when we see hernias, we generally would advise that the surgical intervention is necessary to avert having a complication. So you do not get a complication.
I hear people saying that the hernia is ripe, the more would be thinking that it's now of a sufficient size, that they can't really hide or ignore, or it's causing pain on a regular basis now, as opposed to before when it was probably something a little bit more slight, or maybe only if you do something in particular it's a problem. That's more so what I think people are referring to when they say right. I don't agree with it. I'm just saying that's more so.
Well, I'm happy that we have come, all three of us, we have concluded that we're not waiting for any hernia to ripe. So for my viewing audience, there's nothing that is called letting my hernia ripe. If you have a hernia, and we're going to go into the different types, and if it's not hurting, that hernia should be fixed. So we don't wait until it is ripe, because in most times when it is ripe, that's when you begin to have pain. That's when you have real serious complications. And that's when most times the surgeon is in the operating room with you, 2 a.m., 11 p.m., when you should be home, or that surgeon should be home as well. So we're going to look at the different types of hernia. The classification. Okay, Dr. Wallins.
There's only one or two times that we want to delay. That, first of all, depends on the condition of the patient. And particularly in young children, probably under the age of 2, we may want to wait because they can handle the anesthesia so much better when they're a little more mature. But otherwise in that, we don't want to be rushing into a situation where it's an emergency.
It's an emergency. And that is important, what you have said, Dr. Wallins. We do not want to reach a point where it is an emergency. So we need to done away. And I'm going to be repeating this over and over. There's no ripening of a hernia. To my colleagues, to all the other viewers who are listening, once a hernia is diagnosed, as one of my teachers used to say to me, is a hernia that should be fixed or should be repaired. Of course, as Dr. Wallins has highlighted, there are certain situations where we can delay, but eventually, and in most cases, that hernia has to be repaired or fixed. So the different types of hernias. Dr. Morton, can you just give us, enlighten us as to the different types according to location, how they present, etc.?
All right. Well, there are multiple different ways in which you could classify the hernia. As you said, with regards to location, you have the hernias that occur around the area of the umbilicus, or you could just say in the front of the abdomen. Sometimes you might hear us call them umbilical hernias. You might see us put UH. We might call them superior or inferior umbilical hernias. So you might see an SUH or an IUH. That's just referring to anywhere in the abdomen close to or around the midline. Next, you can have hernias in the area of the groin, which in medical parlance we call them inguinal hernias. So if you look at an abbreviation, you might see us write IH. If it's on the left side, you might see us put LIH, right side RIH. And those are hernias or bulges or herniations anywhere in the area that we call the inguinal area, which, as I mentioned, is the groin, which is the line that basically extends from your hip bone to your genitals, etc. on either side. Next, you have hernias that we're going to call them pelvic hernias. These are ones that protrude through the I'm going to call them pelvic floor, the areas around the muscles that comprise, if you have to think of the pelvic floor, if you're a female, think of the muscles that comprise the area between the vagina and anus, essentially, and all of the surrounding areas. If there's something bulging in that area or in some of the surrounding areas to that spot. And next, the hernias that can occur through weaknesses in the flanks. Those aren't that common, probably the least common on the list, but it is possible to get a bulge or a herniation through what we call flanks are basically the sides of your body. So in terms of the location of abdominal hernias, they are those. With the hernias to the front, you also have epigastric hernias, which are the ones that are really close to the bottom of the breastbone, essentially.
Okay, so normally patients would ask me or would say to me in surprise that, Dr. Will, I didn't realize I can get hernias all over, because most of us, we are just familiar with those that we see in the groin, or we are familiar with those that we see at the navel or the umbilicus. But in essence, you can get a hernia just about anywhere. As Dr. Wallins would have pointed out, once you have a weakness, anywhere you have a weakness on the abdominal cavity wall, then you can have a hernia. And what is interesting, if you look at slide number 7, is the hernia that you can get at the back. Most times, and I think even for some of us in the medical field, would forget about these things.
Yeah, these are two relatively rare findings, but they're seen in high percentage in males, particularly in the age between 50 and 70, and maybe related to work environment and the kind of work that's doing, causing heavy lifting and those kinds of. The top one on the lumbar hernia is hernia of Greenfeld. And the one below, which is over the ilium, is called the Petit, through the triangle of Petit. Those are two which we see, but they're not seen that often. Occasionally, you can be seen in the newborns. And sometimes you can have significant extrusion of viscous in there, because newborns sometimes they have a lot of changes in the wall structure. Okay, we have like there's some special ones we talk about, omphalocele and but the weakness is an area in which the viscous, or it may be just even just a loop of peritoneum, which may pop through, but then itself can cause pain and discomfort.
Okay, so as we are realizing here, all the different bumps and lumps on the abdominal wall, we always have to think it's a possibility that there's a hernia, and no matter where it is. So this is another myth or something that we would like to raise the medical consciousness about, that hernias are not just found in the groin or by the navel. They can be found in the front, in the groin, at the back, in the pelvic area, as Dr. Morton has just said. And it just comes about from a weakness of the abdominal wall. And once you have that weakness there with sufficient pressure, you can get a viscous or part of it coming through that weakened area of the abdominal wall.
I could also just chime in that it doesn't actually have to be a visible lump. Sometimes they just say they have pain on the abdomen, and it's only when you actually palpate and press and tell them cough or force, and that's when you could actually feel it when you press. So sometimes they might not know that it's a hernia, they might just think it's belly pain.
And that is true.
The pelvic floor hernias, particularly see with higher incidence in the female because of the gynecoid pelvis, like the obturator hernia. When you do a physical examination, the patient can sometimes complain of weakness or numbness on the inner aspect of the upper portion of the thigh, which is called a Hauschep-Romberg sign, but you can pick it up on your physical examination. And the patient might be fully aware that they'll have a hernia there until you examine properly.
So let us look at slide number 6 so that persons can understand the pelvic hernias. If you look at that diagram, that's the pelvic bone. And especially the picture on that would be your right. So when you sit on a chair, you feel those two hard bones. So between that area and the bone just below your belly button, you can get hernias happening there. And this is something interesting because even when I was doing my residency, you did medicine before, but you never actually paid attention that you could get hernias in these areas. And what we have to remember, you have muscles that are there. And if the muscle walls become weak, then you can have protrusion or pushing through of parts or a whole organ through these areas. So even as doctors and doctors who work in the emergency room, sometimes we may see these little lumps and bumps and probably think it's an abscess and probably may want to just go and do an IND. And we have to be careful. That is why doing ultrasound, sometimes person will say, but Dr. Woodley, is a hernia, just go ahead and cut. And I would say, no, let us do an ultrasound just to be on the safe side. I've had persons come to my office and say, oh, well, a doctor touched me and tell me it's a hernia and go for surgery. And I said, no, you do not know what it is. It can be just about anything. So it's always wise you do an ultrasound just to confirm your findings. Okay?
Not only to determine if it is a hernia there, but if it has a viscous in it. Because sometimes there can be a protrusion without a bowel or anything in it. Now, if the bowel is in there, then it becomes much more urgent and a serious problem.
And I do agree. So that is where our diagnostic tools come in, and we just can't use our hands. Some of us use our hands as an ultrasound and say, that's a hernia, let's go, surgery. Or send to a surgeon, let's go, let's do surgery. But that's what I admired about Dr. Wallins when I met him, is his respect for the principles of surgery and medicine and the techniques. And I tore that page from his book when I went back to study as well. And you always have to do things the correct way and the right way. Sometimes it takes a little longer than, some persons or patients may want to. But at the end of the day, our priority, our objective is patient safety. Okay?
There are no shortcuts. Pun intended.
Yes, there are no shortcuts. And I do believe in that. There are no shortcuts. Now, we also have another classification that's very important when it relates to hernias. And that's slide number 8. Can you get me that, please? And Dr. Morton, just enlighten us again about this. This classification is very interesting as well.
Yes, so amongst the ways in which you could classify a hernia, you could also classify it based on whether it was something that you were born with or whether it was something that you developed. So as Dr. Rollins was saying, when he spoke about the hernias that could develop in the back, he was speaking about acquired hernias to some degree, but he also mentioned that you could be born with it or a newborn, and that's where this classification comes from. If you have a hernia in which you have an inborn defect in your abdominal wall, then that's a congenital hernia. But we are human beings. As we're going through the cycles of life, different things may happen to us which can make us develop hernias onto an area that otherwise was previously, let's say, normal. And the main way in which you see people acquiring these hernias is if they've had an abdominal surgery. So sometimes someone has some kind of other emergency in which they need to get some kind of bowel surgery done. It could be some obstruction somewhere. It actually could have even been a previous surgery for repairing of a different hernia of some sort. But once you have made an incision into the abdominal wall, if you think about it, you have cut into the continuity of the muscle and tissue. And even though you would try your hardest with regards to stitching back all of the layers and being very meticulous, the area that you disrupted, it's going to be an area of potential weakness. And that's where you can develop an incisional hernia in an abdominal wall, which otherwise was normal before, which also again highlights the importance which was being mentioned, that before you perform any surgery, you have to be very, you have to look at the pros and cons, be sure that you actually have to do this procedure, because even when you do something to help someone, it can have potential complications. So Essentially, that's the classification with regards to congenital versus acquired.
So the congenital are the ones that the babies are born with, and the acquired, well, as the name implies, as you go along life, you happen to get them for different reasons. Dr. Rollins, what is your take on this type of classification?
Well, that's standard and a well-established way of delineating the type of hernias present. There are some factors which may make it more likely for incisional hernias. There's one, inadequate or improper closure, put the tissue back together. Infection, so the bone become infected, it loses its strength. And number three, the nutritional status of the patient. They don't heal very well. And so those kind of things can predispose to incisional hernias.
And that's something important you have mentioned, Dr. Rollins, the nutritional status.
Yes.
And persons don't realize in order to heal, your nutritional status has to be up to date. You have to be eating correctly. Sometimes I do feel as doctors we probably drop the ball here because we don't tell our patients what to eat even prior the surgery. Sometimes we have to prep them and say, or sometimes when we look at our patients, you say, you know what, you need to beef up a bit, you need to eat a bit more, you need to get some nutrients. And I sometimes do, and they would ask me, but why we just don't go and do surgery? I said, no, you need these nutrients because after surgery is an insult to the body. Surgery is an aggression to the body. So you're basically going to war when you're doing surgery. So you need to have all your resources up to scratch so that after the surgery, you can heal well and heal within an appropriate time. So the nutritional status which you speak about, that's super important because if it is not up to scratch, then healing is delayed. Once healing is delayed, then that is why sometimes persons come back with a recurrent hernia. And they will say, well, Dr. Woody, you didn't do it well, and look, it's back now. But sometimes it's multifactorial, the reasons why this would happen as well. As you rightly said, technique, super important. If it's not done well, then we know within a year or so, the person will be back. But the nutritional status is super important. Also, persons who have other comorbidities, we also have to make sure. So sometimes as a surgeon and persons come to me on a Monday and say to me they want to go on the bed on a Thursday, I said to them, no, that can't happen. I need to actually check out, see what's going on with you. Just have a talk with you because there are so many things. You could be diabetic, hypertensive. We have to get all of this under control because one of the worst things is to put a diabetic on the bed who's not controlled. And then a week, 2 weeks, 3 weeks after the wound now, as we would say, seeping, it's infected. And that's because we did not stop and pause, do a proper history, know what is happening, do proper examination to see what is going on. So that is very important as what you spoke about in terms of the nutritional status, getting your house in order before you actually put somebody on the surgical table. At this juncture, we're going to take a break and hear from our sponsors, QDL, Quality Diagnostic Lab. We want to thank them for sponsoring the show, demonstrating their continued support to science, to medicine, especially here in the Federation of St. Kitts and Nevis.
In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance.
Welcome to the beautiful islands of St. Kitts and Nevis. Today, we'll be spending time with the Wilberts. They're a happy family that love liming, and with plenty of food and drink to go around, life is good, but not for long. Sadly, the Wilberts never paid attention to what they ate or drank. And when asked to reduce those sugary drinks, they joked and said, "We will, but not today." Unfortunately, a year later, Mr. Wilbert had a stroke. And a few months after that, Mrs. Wilbert was diagnosed with diabetes. From hospital bills and the cost of drugs to time off work, this began to take its toll on the family. But it wasn't until they saw the effect it was having on their children that they finally decided to make a change. You see, the Wilberts realized their family was already sweet enough, and a healthy lifestyle was the best gift they could ever give them. What gift will you give your children?
Pleasant good night, and thank you for joining HealthWise by the St. Kitts Nevis Medical and Dental Association. Tonight we are discussing letting my hernia right. And here with me in studio is Dr. Lawrence Wallins, General Surgeon, and I also have Dr. Jensen Morton, District Medical Officer. So far, we have come to the general consensus that we are not waiting for our hernia to right. That is an ideology that we should get away from. And we want persons, once you have a hernia diagnosed, please find your surgeon. We looked at the different classifications. We spoke about the classifications according to location. And what we realized, or what we would have said and demonstrated, is that a hernia on the abdomen can occur on the front, at the back, and at the bottom of the abdominal cavity. Remember, the abdominal cavity is a cylinder. So you can think of it that way, so you can understand where hernias can be found. Many times persons are surprised outside of the navel hernia and the hernia in the groin that you can get hernias elsewhere on the abdominal wall. We looked at also the hernia classification based on etiology, or when it appears. The hernia can appear at birth, so we call that a congenital hernia, or it can appear during one's life, and we call that an acquired hernia. Dr. Wallins alluded to the fact that the acquired hernias most times would develop based on poor nutritional status, sometimes if you had a surgery before, and as Dr. Morton had said, having a surgery before actually weakens the abdominal wall, thus putting that person at risk at developing a hernia. The last classification we're going to look at would be what you see on examination. And that would be, for us, slide number 9, please. So, Dr. Wallins, what is your input on this classification? Because sometimes it can get confusing, and I know we have medical students looking at, the young doctors just coming out of school. Mm-hmm. And do you like this classification that you see on examination?
Well, it has its merits in that you have a hernia with basically just preperitoneal fat being involved in there. You can have a strangulated hernia, which is a extreme in that what strangulation implies that when the hernia or what's in the hernia, maybe bowel, and the tightness around it is such that it cuts off the blood supply to the intestine or tissue, and that can cause significant pain or a severe complication in that sometimes that segment of bowel has to be removed, and you don't want to get to a situation where that will happen, because that's an extreme complication of the bowel becoming gangrenous, and because it's strangulated. Now we have incarceration. That means whatever has gotten down into the hernia cannot be reduced. Now, when I say reduced, it can't go back in. And that is significant in itself. That is even where we could say is an urgent need for it to go in. Now, when you have a strangulation, that is an emergency intervention that is needed, surgical So you can, that's a reasonably good classification. You can break it out to subgroups, but this is pretty sound classification of the different types of hernia and how they will present.
So, Dr. Morton, I'm looking at this cartoon thing here. I know you're on the younger end, so you can probably speak to that, the younger population. This cartoon, I found it very interesting.
It is.
Yeah, so can you just explain it to us, please?
All right. Well, in looking at the cartoon, as it says, they use the term SIR to abbreviate whether it's strangulated, incarcerated, or reducible. Strangulated, as you could see, the person that's the criminal, they are actually stuck in the bars, meaning that that's why Dr. Rollins called it an emergency, because the bowel contents, not only can they not move, but the blood supply to that area is being threatened. So it's nearly like something has plowed through a small space, but a ridiculous amount plowed through that small space because of a sudden pressure or something. And it is so much that it's now compressing on the blood vessels in the area. And that's what they mean by strangulated. And as he said, it's an emergency. So as incarcerated is saying, this is when the part of the bowel or whatever viscous, that it's penetrated through the weakness, and it is in such a way that it can't go back in where it came from. But as much as that is the case, the blood supply is still intact. So it's not an emergency, but it's still an urgency, because if it's incarcerated, at some point in time, it can become strangulated. So rather than waiting for it to turn into an emergency.
Or getting ripe.
To me, that looks like green, ripe, and rotten. You have to try to deal with it. And then the reducible, as you could see, the person, the jail cell is open. All that means is that it's an area in which it could protrude out as it's rubbing on the surface and it's coming out. It's probably causing a lot of pain. But then if you tell the person relax and you push it back in, then whatever viscous, it can actually go back into its compartment. And I mean, sometimes it still causes some residual pain, but usually that's what people would feel in terms of their own experience.
Yeah, and sometimes you don't have to have a viscous in there. It can be a small loop of fat.
Small loop of fat.
But when that fat becomes incarcerated, it can't go back or move. Sometimes maybe adhesions to it, to the protruded area or the sac itself, and that can cause severe pain. Even can cause vomiting, even though there's no bowel in there, and cause significant pain from it, and there's just a piece of fat in there. But that in itself would be an indication for immediate surgery to have that taken care of. Okay. So it's not just only the bowel. Of course, it's obvious when they have bowel that is trapped and can't be removed, can't go back in. Then it becomes an urgent case.
Because sometimes we would get ultrasound that is done, and it would say just some bowel fat is some fat is being protruded through the opening, and then the mom would say, but if there's no intestine, but why is she vomiting? Why does she need surgery?
Yeah, once you have probably even a little bit of omentum or fat in there, that itself can provide pain. Now, pain in the bowel. For instance, if I were to open the abdomen right now and the bowel out there and I cut it, you probably won't feel anything. But if I were to blow it up like a balloon, stretch, then you get severe pain. That's why people with intestinal obstruction have so much pain. And so the same thing occurs here when you have a bit of omentum or fat trapped within the hernia. It can cause significant pain and vomiting and nausea, even though there's no bowel there.
Okay. So we're going to look at slide number 11 as it relates to the acquired hernia. And this is just a simplified version of what happens. I mean, Dr. Rollins, you would know it goes much deeper than this. But the objective of this show is not for you to become a surgeon or a medical doctor. The objective of this show is for you to identify when something is wrong. What we're doing is raising the medical consciousness here, letting you know when something is wrong and that you need to seek help. Do not wait for it to ripe. You go straight looking for help. So, Dr. Morton, as we see here, we have causes of an acquired hernia. Just explain to the viewing audience the simplified version of how a hernia is actually acquired or produced.
All right. Well, for the hernia to be produced, as we've been alluding to, two things have to really be in place. One, there has to be a weakness in the abdominal wall, and the other one, as you see there has to be an increase in the abdominal pressure. Now, a variety of things can be the source of this increase in abdominal pressure. It could be from someone that has a chronic cough. It could be someone that you're straining to pass stool, so you have constipation issues. It could be someone that's straining to urinate if you're an older person with some untreated prostate issues or some other issues. It could be from, the classic is heavy lifting. That's the classic one, from someone that lifts something that's just too heavy. If you're a child, it could just be from running up, like a lot of activity, running up and down, all of that. But once you do anything that's going to be increasing the pressure in the abdomen and you have some kind of weakness along your abdominal wall, then those contents of your abdomen, which are packed in there very tight, I was going to say if anybody ever saw, it's so brutal, I don't want to mention it, but if you ever saw like someone's belly get cut and how everything just blows out, it sounds kind of bad to say it, but if you ever witnessed a butchering of something and you realize once you cut the belly, how the content like blow out, because everything in there is packed. There's a lot of pressure, it's packed in there tight. So if you have a weakness on the wall and this area which is designed to be under pressure and you're going to increase that pressure, it's going to find that weakness and it's going to try, the contents are going to try to bulge through. And that's the underlying basis of the hernia.
Well, many people have seen when you have a tire on your car and the side wall becomes injured, a weakened area, it bulges out. But that is analogous to a weakened portion of the abdominal wall, which can cause a problem. But usually it's much larger than that. But and you won't get any obstruction from that. But it's analogous to how tissue can become weakened and present with a bulge, and that area could quite easily blow out in a tire.
Okay, and that's very important. And also family history. I don't know if Dr. Morton mentioned that. Most times if a dad had a hernia, mom had a hernia, chances are there's some genetic weakness of the abdominal wall which can be passed on to the children. And sometimes children do follow their parents as it relates to getting hernia as well. Something that is popping up here and I'm seeing is smoking.
Very much so.
And I have a lot of young fellas, 19, 20, with large hernias. It's things that you would see in probably somebody who's already 65 and over 70. And most of them you would get the history that they are smokers. And it is posing a problem because a lot of our young men are coming in with large hernias. However, on that note, we're going to pause again, go get a snack, get some water, and come right back. Let us hear from our sponsors.
In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance.
Hi, pleasant good night. And if you're just joining us, we are speaking about abdominal wall hernias. And all three of us, and I know those who were listening before, we have come to the general consensus that a hernia diagnosed is a hernia that should be fixed. Of course, we have some exceptions, but go to your doctor and let him or her decide the cases that are the exception. We have looked at so many things so far, and we were just about to speak about the formation of hernias and its relation to smoking. Now, if we look at slide number, this would be number 12, you realize that the abdominal wall is made up of muscles, tendons, etc., and bone. And these structures, they have a protein that we call collagen. This is what gave the abdominal wall that strength. That is what allows the abdominal wall to keep its contents within. Now, for persons who smoke, they actually cause damage of this collagen. And when this collagen is damaged, then the abdominal wall is weakened. Especially persons who do smoking with nicotine or the cigarettes, this is normally a problem. So what I find happening is that I have persons, young persons, who would have started smoking at an early age, 15, 16, smoking cigarettes, smoking some things that they call brown, which has a mixture of marijuana and cigarette, tobacco. You normally find these young men at age 19, under age 25, with abdominal wall hernias, and not just small abdominal wall hernias, large abdominal wall hernias. So this is actually a risk factor. I don't know how we're going to get around that, because as we know, the smoking and those type of practices, they have become quite common. Okay, so
any sort of combustion product that you routinely put down into your lungs is going to cause respiratory problems. And with that, coughing, and it may end up having you have an increase in the abdominal pressure. So,
and that's a very good point as well that you have brought up. So there are two things. It's like a double whammy. One, the smoking and the content of the whatever you're smoking would damage the collagen, which gives strength to your abdominal wall. And as you say, any combustible would cause respiratory issues. Hence, that person will be coughing a lot. Hence, you get weakened abdominal wall, increased abdominal pressure, hernia formation. And as you look at this slide, as you can see, smoking causes a decreased rate of collagen formation. That means your abdominal wall is weakened. This is due to the effect of nicotine. Look at this. Persons who smoke are 4 times more likely to develop a recurrent hernia. That is a hernia that was fixed and would have returned. Smokers are more likely to develop infections after surgery. We recommend that all smokers stop smoking prior to hernia surgery to prevent this dreaded complication. Sometimes that is impossible. I tell my patients, please don't smoke. Or they will say to me, Doc, I haven't smoked for a long time. I would ask how long ago that was. And they will say to me, oh, since I got admitted to the hospital. And so I would say, well, that was just 2 days ago you got admitted to the hospital. And for them, that's a long time. But the smoking, it's a dangerous practice when it comes to your health. And I am repairing so many hernias in young men that when I was studying in Cuba, those types of hernias and the size of those hernias I saw in men who were over 60 and 65. So that's a problem we definitely have to deal with. I honestly don't know how we will get around that, but that's something that we have to look into. Now we're going to speak about something that is interesting for you to understand the signs and symptoms, or the symptoms you will get when you have a hernia. And that's on slide 15. The different parts of a hernia. As you can see quickly, you have a ring or a neck. That's where the hole is on the abdominal wall. You have the content, as the name implies, what goes through the abdominal wall and occupies that space. And you have a sac. The sac is like the plastic bag that covers the content. And then you have the hole at the base there. So we're going to look at signs and symptoms. And Dr. Wallins, I know you have been in this for such a long time. What advice can you give to our viewers as it relates to signs and symptoms?
Well, the first obvious sign is the actual bulge in the on the abdominal wall where the hernia protrudes through the weakened area. Now it may progress to pain and discomfort, change in bowel habits if it's large enough. Okay. And if it becomes incarcerated, that means it cannot be put back in. There's even a more serious and more urgent complication that you need to take care of. Okay.
Okay.
Nausea can be associated even if you don't have bowel in there, you can still get nausea. Okay. And you have intermittent problems with eating and bowel habits as associated with any partial or incomplete obstruction associated with bowel caught within the hernia sac.
Okay. And Dr. Morton, in your practice, what are the most common symptoms a patient would come to you?
The most common symptom, it tends to be pain.
Pain.
Well, I see lots of children with it, and it tends to be that the parents saying that the child is having pain. It's normally an umbilical hernia, and the child is having pain when they run up and down, and then they have to lie down flat and calm down, and it tends to go away after a while, but the belly is always hurting them. Sometimes there's vomiting with it because of the same triggers which were mentioned. There's the pain is more common, the bulge is there. If I had to say those which I saw today, well, one of them was an inoperable incisional hernia. One was a child with a really small but painful hernia. Another one was another child with a hernia. So if I had to ratio it based on today, then that's the ratio. But it's usually the pain plus the bulge plus vomiting, and they can usually pinpoint exactly the area, or if not exactly, around the area with which they're having the pain.
Okay, and that is true. So, but something we also have to mention, sometimes you have no symptoms. Sometimes you may be doing doing just a physical examination on somebody, and then while examining the abdomen, you just feel the defect or the hole on the abdominal wall. And then you sometimes would have to tell the patient, hey, you have a hernia here. And the patient would say, I didn't realize, I did not know.
Sometimes they know and they say they're not fixing it.
Okay, sometimes they say they didn't know. So you can have the bump, you can have the pain, you can have both. And sometimes you can just not have anything at all. And the other symptoms, as Dr. Rollins was speaking about.
Many times on examination, you can pass your finger up, the little pinky finger, little finger, up to the inguinal canal and get the patient to cough. And we call it the silk sign. You can feel when the hernia comes on, when the person coughs, because that's now increasing the intra-abdominal pressure. And you can feel the hernia, which may not be a big hernia at the time, but it can later on develop to a larger hernia if untreated.
And something that I was taught at school, because sometimes moms bring babies, little ones, and you, the doctor, would not see the hernia. But the mother would say to you, I saw the lump, I saw the bump. My teacher would always say to me, believe the mother. And when it comes to mothers, if they're not persons who you see obviously not taking care of the children, mothers normally say what they see, and they're normally truthful about what they see occurring with their children.
So. And particularly when the baby's crying.
Particularly when the baby is crying, because that baby may come to you because I think today I had a child. The mother said the child had a hernia, but once she brought the child to me, it disappeared. But I believed her. And we are in the era now of phones and taking photographs. So I said to her, the next time it comes up, just take a photograph of me. But I believe her because she saw it.
It's a small child, a little simple thing like tickle the kid. And that increases, and the next thing you see the hernia. So little things you can do sometimes to elicit the protrusion of the hernia.
That is so true. Okay, so we're going to look at slide number 17. That is a slide. And Dr. Rollins, have you ever seen anything like this in your practice?
Oh, yes. These are large inguinal hernias. We in Sink it's called Bamanku.
Yeah,
but it's a West African word.
Oh.
It's come from a West African word, which is very similar in many times this accompanied by what we call loss of domain, in that you can't just put it back into the bowel, into the abdominal cavity right away. Now you have to do things to do. I remember having a case where the appendix, patient had appendicitis in the scrotum. The appendix and the cecum was all the way down in the scrotum, and they had a gangrenous appendix in the scrotum. So that's so you can get the complication. But however, how we treat those, a lot of people don't like to tackle them, but because of loss of domain,
look fixable.
they can be done. Now, what we did used to do.
So I guess I can call you if I have one of those.
What we do is it'll take about 10 days to prepare the patient.
Exactly.
Now, what we do is take regular air, filtered air, and you inject it in about 50 cc amounts into the abdomen cavity with the scrotum down here. And as you increase over many days, you allow the abdomen to expand. But you can't do it all at once. So it takes about 10 days or so to get it light enough. So you can stretch the abdomen. And we have to do it slowly because you don't want to embarrass the respiratory, the diaphragmatic movement. So you don't have a complication with that. After you've done that, and the patient is otherwise stable, no nutritional problems, then you go ahead and do the surgery. During the surgery, you're going to have to cut the inguinal ligament because it's large. And you may be able to reduce the whole hernia, put everything back into the abdominal cavity. But it takes preparation. It takes preparation to do that for the large inguinal hernias.
So you would have to expand the
abdomen. Expand the abdomen. Use air because air is 70% nitrogen and it's not absorbed very slowly.
Very slowly, yes.
So you can do that and expand the abdominal cavity and put everything back into that.
But we don't want persons to wait. How long somebody would have had to wait for this to happen?
Well, it depends upon the weakness and the strength. Because sometimes that would take years.
That would take years.
Years to get developed that size.
That would definitely take years. And look at slide number 18. So here we have the perfect demonstration of an incisional hernia. Okay, so how, as a surgeon, how can we avoid things like these?
Well, you have, first of all, there's several things. Meticulous reconstruction of the abdominal wall, very meticulous. It requires not entrapping fat in your suture, in your suture line and the tissue. All these things lead to breakdown of the wound itself. Using the proper sutures, proper super strength, so that the sutures don't burst, etc. And of course, preparation before the surgery, if the patient did proper nutritional status, the patient is adequate. So these are things which you want to be sure. And of course, if you get an infection, of course, it's more likely to develop an incisional hernia in it. The thing about incisional hernia is that quite often they're accompanied by adhesions in there. And so you have to be very careful with your dissection too.
I was just asking as a side note, putting a mesh in there, does that reduce the chances of an incisional hernia?
Well, mesh, if the defect is large, then you may require using a mesh. In the old days, we used to put on what we call Montgomery straps, and over a matter of days, increase the tightness of the wound to bring it back into with a large effect.
Something you wrap around the belly?
No, well, no.
I don't know what it is at all.
Okay. We'll explain it later, but it would bring the bowel, the edges back together slowly over several days. And the reason for doing that is if you don't want to embarrass the respiration. If the abdomen is too tight, then you can't breathe properly. So you have to do it gradually and bring it back together. Otherwise, you can put in a mesh if you have a serious defect in the wall and you have to close the abdomen around a mesh. But that's not the most satisfactory situation.
Okay. If we look at slide number 19, where we're at here, So we have already come to the conclusion that we're not waiting for any ripening to happen, because in most cases when the hernia is ripe, that is when we see complications, and normally it's an emergency situation where we have to take the person running to the operating room. If we look at slide 20, we're going to see, and we have to show these pictures because persons may think we're just talking, and I know Dr. Wallins, you would have had experiences like these. I'm just, well, I'm not so new in the business now, but I've had many complicated hernia procedures when persons could have, gone to their doctors earlier and avoid having these type of complications. So as you can see on the left, that's what we call necrotic or bowel that is dead. And obviously this surgery now is not a little simple incision, but most times you have to do a big open, which we call a laparotomy, and you would have to go in and you would have to resect or cut out bowel. My last case of this, I had to remove probably about 2 feet of bowel for a gentleman who actually postponed his surgery for that Thursday, but he ended up in the emergency room on the Sunday. And when I got the call and they mentioned his name, I was like, wow, that was a gentleman who had to go to the operating room late that night, spent about probably 2 hours inside there, where I had to resect that amount of bowel. And the problem with bowel resection is that the bowel has a function. It's to absorb nutrients. So it's not just to resect and hip hooray, you move on. When you resect, that person now would have lost that surface area where absorption of nutrients should have been taking place. And then that person then suffers from malnutrition. And that patient of mine, he has lost quite a bit of weight. Eventually, as we know, the colon, the right side of the colon would take on some of that responsibility that lost bowel would have done. But in the interim, he has lost a lot of weight. He had to deal with a larger incision that wasn't necessary had he come that Thursday. And that is why we are urging patients, we are urging our colleagues as well. A hernia diagnosed is a hernia that should be repaired.
And we disregard the term ripe.
And we disregard the term ripe. There's nothing about ripening of a hernia. So at this juncture, we're going to take a break and we're going to allow our viewing audience to call in. If you want to be a part of discussion, call in with your experiences, and your experience can help someone who is listening as well.
In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance.
Welcome to the beautiful islands of St. Kitts and Nevis. Today, we'll be spending time with the Wilberts. They're a happy family that love liming, and with plenty of food and drink to go around, life is good, but not for long. Sadly, the Wilberts never paid attention to what they ate or drank. And when asked to reduce those sugary drinks, they joked and said, "We will, but not today." Unfortunately, a year later, Mr. Wilbert had a stroke. And a few months after that, Mrs. Wilbert was diagnosed with diabetes. From hospital bills and the cost of drugs to time off work, this began to take its toll on the family. But it wasn't until they saw the effect it was having on their children that they finally decided to make a change. You see, the Wilberts realized their family was already sweet enough, and a healthy lifestyle was the best gift they could ever give them. What gift will you give your children?
Thank you for being with us so far in our program. And we have been discussing letting my hernia ripe. In fact, I think we will stop using that phrase now, because we have come to the conclusion that there's no such thing as ripening a hernia. That is a myth. That is something that we should done away with. If you have a hernia, get it checked out, get to your surgeon. A hernia diagnosed is a hernia that should be fixed. So if we look at slide 22, if my producers can give me that slide, please. 22. That's 22. Oh, 21. Sorry. So this is another leaving your hernia to ripe. What we call is intestinal obstruction. Dr. Rollins, can you speak to this?
Okay. In a case where the bowel it becomes obstructed because it's entrapped and it can't go back in, or it's so tight that the normal transit time for the material within the intestine cannot pass through. And so the bowel becomes obstructed. That's why we say obstruction. And it can cause nausea and vomiting. Okay. And the lower down the obstruction is, the more what we call feculent or fecus-like the vomitus becomes. So, but you can get that in a low distant small bowel obstruction. Can give you feculent vomitus as well. Doesn't have to be colon.
And then this is a hernia that we definitely would have to rush to the OR with.
That's going to require emergency procedure, because you can't let it go for too long, because the problems attended with obstruction, all kind of metabolic problems associated with obstruction and inability for the bowel for the food material to transit the bowel can cause significant problems. So, not to mention, if it stays too long, you don't know if it's going to be get incarcerated. If it becomes strangulated, rather, then you have to. That becomes another complication.
And if you look at slide 23, persons normally, that's one of the first things. I mean, they don't care what happened on the inside. Everybody just wants to know, the incision, what's on the outside. And I would say to them, but you haven't even asked me what took place when I went in. The first thing would be like, Dr. Woodley, why this incision, or why you did this? But look at the incisions that one would get when they allow their hernia, with inverted commas to ripe, as opposed to going to your doctor, your surgeon, on time. So if you look on your left, you get those small, nice, neat incisions. You get a nice closure. With that closure, because it's in a crease, most times you don't even see the incision. As opposed to waiting when there's a complication, then you end up getting what we call a laparotomy, because we have to explore, and you get that midline centipede, as Dr. Morton has said. But I try not to do the centipedes anymore.
More extensive procedure. Well, you can use different clothing techniques to ensure you don't have a large scar like this.
So Dr.
Some particular stitch,
which is nicer. But then, as you would say too, that depends on the habitus of the person.
Yes.
That depends on a whole lot of things as well.
Depends upon the subcutaneous
tissue, etc., etc.
A lot of factors.
A lot of factors involved. So, Dr. Morton, what would you tell your patients?
From now on?
From now on. Because I don't want to send into my office now and telling me to ripe any hernia, which you have never done. So I don't think you would start either.
No. I will continue every time I identify a hernia. I always refer one time. I think the easy part from my end is just that from the time it's identified, it's just to let them know there's a hernia there, and just always tell them you have to go have a conversation with the surgeon to try to basically determine a time to get a nice, safe, elective surgery done, such that it does not turn into an emergency. So that's the easiest way to handle that, to be honest.
And if you look at slide 25, as Dr. Wallins would have said earlier about waiting, there are some instances where we don't rush into it. For example, Dr. Wallins, you can speak to that.
Yeah, here's a young infant with a large hernia. Now, by and large, most of these hernias can easily reducible because of the size. And particularly if the base of the ring is wide, then it's not as urgent as somebody who has a small ring with a large sac. If it's a small ring with a large sac, then more bowel can get into that and can't be reduced. But with a large ring, then you can reduce the hernia and you can take your time and go on and have it fixed because it will get larger.
So normally in these cases, I would normally tell my patients, because the ring most times, as you say, it's pretty wide, so the content can go in and out. We normally advise our moms, for the umbilical hernia, let's wait until your child is about 3-4 years, and if after that it hasn't closed off, then you may opt to do surgery. I sometimes even observe a little longer.
Yeah, well, the urgency would be dependent upon the size of the ring.
The size of the ring,
If the ring is very small and you have a large looping sac, then the possibility of obstruction is greater. So you may want to go in at an earlier period of time. Now, if it's like the one we just saw on the slide, if it's a large one which can be easily reduced and is not as urgent, but it should be fixed because it will get larger.
It will get larger. And something that we have to really pinpoint, and that's slide 26. Unlike the hernia at the navel, which we can give time to, the hernia in the groin for children, we have to pay special attention to them. Correct. Because the ring is much smaller, the same thing as you're explaining, a little more rigid, and these are the hernias that tend to complicate. Okay, so I know we have a lot of moms out there for our younger doctors who may be seeing patients, maybe seeing babies, and you may see a hernia in the groin and may want to tell the mom to wait. That is not the best advice. Let the mom go and see the surgeon because in most cases, that hernia in the groin, it has to be fixed. About 3 months ago, I had a child which was born premature, and that's another risk factor too for acquiring hernias is being born before 38 weeks, preterm, and that is a cause, a risk factor for getting hernia. So these hernias in the groin, we do not play around. I had a bilateral, we had to fix both. And that same baby has an umbilical hernia, but it is getting smaller and smaller. So we do not, waste time with the groin hernias in babies. How do we treat these, Dr. Wallins? That's one of the biggest things. We have been speaking about don't let it ripe, get it treated. So what type of surgery do you do or used to do?
Well, for those umbilical hernias, that's just relatively straightforward. You have to go in, repair the defect, that is between the edges of the ring, close it, and after having reduced the hernia. Now, for the groin hernias, inguinal hernias, you have to make an incision and take it down to what we call for the indirect, what we call two types of hernias in the indirect and direct hernias. Most of the time in the children, little kids, you'll find indirect inguinal hernias. That is due to the passage of the testes from the abdomen down into the scrotum. And you have the processus, what is called the processus vaginalis. That is a cylindrical tube through which the testis has passed, and that leaves a weakened area which should normally have closed off. And it's not closed, and so you have bowel which may herniate through that groin hernia. And what you have to do is go in, reduce the hernia, put the bowel back in, and that sac, which is there, you have to close the sac off. And in little kids, we use high ligation of the sac. If you reduce the sac, ligate the sac, tie it off. And you may not need to do one of the major repairs, like what you call a Cooper's ligament repair, or one of those other repairs because in the children, but you can close the ring a little bit more in the smaller, in kids. Now in adults, you may need to do a little more entailed repair. Okay, like we can use a Cooper's ligament repair, McVeigh repair, etc., to strengthen the flow and to close the ring effectively. Yeah, so you do that in the adults, but there are places where hernias are done on the local anesthesia. There's the Shoulder Eyes Clinic in Canada. That's all they do. It's hernia repairs.
But when I was at school as well, I did all my hernia repairs on the local anesthesia.
But you can't get them done in little kids because the kids have a wholesale. So adults who will wholesale enough, and once you inject them up and use the local properly, you can get the hernia done properly. And patients have less problems from the repair.
And that's something important you have mentioned in terms of the anesthesia. Most patients like to go to sleep, but as I said to you earlier, when I was at school, in adults, all my inguinal hernias, we did them on the local anesthesia.
Well, it depends on
depends on the size as well. But where I
size.
studied, because the medical consciousness is so high, I really saw what we call the bamanko, because as soon as a hernia appeared or was detected, it was fixed.
Well,
it was fixed.
Well,
okay.
We used to see bamankus around, but I haven't seen one in quite a while because people have been getting their hernias fixed. But you see that? Have you seen recently?
Dr. Morton said he saw one today.
Oh, that's unusual.
But I am seeing quite a bit in our young men that where you have the inguinal hernia, and I have fixed quite a few in the past. It's not as huge, but given time, I mean, these guys are 19. If you give them about 25, until age 25, it would be, the classical bamanko, as we would call it.
Anyway. Yeah.
So let's, Dr. Morton, let's take opinion in that. So, Dr. Morton, what was your advice to that patient with the bamanko that you saw today?
It was it came with documentation to say it was irreparable, as in it was signed off as such.
Cannot be fixed.
It didn't come for that.
Was it reducible?
No.
You couldn't reduce it.
The ring, it's a massive ring, so it's going to be a complicated surgery no matter what.
Well, it can be done, but it takes time.
It takes time, and it takes resources, and it takes everybody of the team to know what is happening and understand and appreciate what is happening, because you cannot be the only one who thinks it can happen when the other persons around you are saying no. You never be successful. Okay, if you want to call in to be a part of this discussion, you can call 466-2666, 662-8674, 767-4765, and the overseas number is 1-239-645-4500. And just before we close, we're going to look at mesh. A lot of persons come in with the idea that want to put a mesh in, it's going to move, it's going to migrate, and they was looking at television and they saw that somebody had a mesh in from the groin area, and the mesh ended up reaching up in the thoracic cavity, and the stories are great. So as it relates to mesh, well, Dr. Morton, I'm going to ask you, have you had any experiences, anybody who came to your private office and would have had a mesh in?
In St. Kitts, no. I saw more meshes being put in place when I was in Jamaica. They used it more often. But I never saw a migrating mesh. It used to be sutured.
Yeah.
So I don't know if it takes many years or something, but I never saw a mesh complication like that.
No, I haven't seen any of the complications for mesh. The mesh is usually indicated when there's particular attenuation or weakening, significant weakening, a large segment of the fascia which you want to or the ligaments which you want to make the repair in, and you would actually suture it in place, so it's not going to migrate anyway using a non-absorbable.
So where do you think that came from?
I don't know. I don't think if you put it in, it's hardly like to be able to migrate all the way up to into the chest cavity.
So like a car accident.
But that is a very big concern because I use a lot of mesh. I also practice in St. Lucia, and all surgeons, they use mesh. It has become standard practice in some hospitals throughout the world.
Well, I would use it when there is a weakness and they need to strengthen the floor.
Because,
but otherwise than that, if it doesn't have that indication, I don't use it. But when there is a need, if the floor is very weak, then you can't have a good Cooper's ligament to sit. Then you would want to put a mesh in.
So this, and I normally tell my patients, once the mesh is sutured in correctly,
it's not going away,
and the sutures are good, the technique, and that is what's important, the technique of putting in the mesh, and you have to know how to put a mesh in too. So if you don't know how to put the mesh in, then probably that may be one of the reasons why you get those, crazy migrations and what's not. But I normally tell my patients, once you put a mesh in and it's sutured correctly, it is not going anywhere. What I find happening though in my smokers, most of them, as you would have said, Dr. Wallins, because the posterior wall that we have to fix at the end of the surgery is so weak. And when we say weak, you hardly have any muscle structures there to actually put back the posterior wall. In most of my patients who smoke a lot, I have to use a mesh. Of course, a mesh is a foreign body, and some persons have serious reaction to these meshes, and sometimes it takes a little longer for them to heal as opposed to the person you would not have used the mesh in. So everything runs, everything has its downfall. Although it is a good practice, sometimes you can have problems using a mesh. So as I said to my smokers out there, I am once again appealing to you, please quit. Please. I am getting just so many hernias in young persons that the figures there, it's a bit alarming now that you're seeing so many young persons with these large hernias getting to the point of what we call the Bamanco, and they're just 19, 22, 23. Sometimes they have bilateral, and they're so huge, and we normally get the history of smoking. So we're basically going to wrap up now, and I'm going to have Dr. Wallins give his closing remarks, followed by Dr. Morton.
So I'd like to advise most individuals, particularly the parents and the mothers who have young children, and they do detect hernias, whether umbilical or groin hernias, to have a surgical consultation and have the hernias evaluated for repair. Not just to look at, but to have them repaired, because the consequences of non-repair can be quite serious and can be quite catastrophic. And so young individuals, particularly small kids, can't tolerate those kind of insults as a more mature individual can. They will have respiratory problems, metabolic problems, all sorts of problems which they can't handle. So therefore, from what would one consider a simple thing, you can get a major problem. So the care is to have the hernia repaired as soon as it shows itself.
Dr. Morton?
Okay. I would take more the route of the prevention part. It's to try to limit. I would depart by telling people, try to limit their risk factors with regards to the development of a hernia. So try to get your weight under control. Try to quit smoking or drastically reduce the smoking until you've reached a point of being able to quit. Make sure that your nutritional status is up to date, that you're getting adequate protein in your diet. With tying in with the obesity part, even if you're trying to lose weight and you're exercising or you're gymming, do not overexert. Do not lift beyond your capacity one day because you're surrounded by a bunch of people egging you on. At the job, also know your limitations. If something is too heavy for you, nobody has to force you to lift it. You could get assistance or whatever it is. So try to prevent putting yourself at risk. If you're having a chronic cough, try to get it dealt with. If it needs to have the underlying cause addressed, or if it needs some medication to address it. But doing those things, you're going to reduce your risk factors for the development of the hernia in the first place. And in the event that you get a hernia, as was stated, to try to get it repaired as soon as possible.
Okay, so as it relates to our topic, letting my hernia right, that does not exist. A hernia diagnosed is a hernia should be fixed. A hernia diagnosed, as Dr. Rollins would have said, should be evaluated by a surgeon with the intention of getting it repaired. An ounce of prevention
it's better than a pound of cure.
Is better than a pound of cure. We want to thank you with the association, the executive from the St. Kitts Nevis Medical and Dental Association. We want to thank our viewers for tuning in tonight. As usual, we are sincerely grateful for your support. And persons can call in to ZIZ and give topics that you would like us to discuss so that we can raise the medical consciousness of the people of this federation. Once again, I say thank you. Have a great week. Be nice. Be kind.
In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance. In these uncertain times, good health is a must. Let Quality Diagnostic Laboratory provide you with fast, accurate results of the medical laboratory tests that you need. At QDL, our qualified and experienced staff can provide a host of blood, urine, and other tests in a safe, confidential, comfortable, and welcoming environment. We are open Monday to Friday from 7 a.m. to 4 p.m. and Saturdays to 12 noon. We are at the corner of Fines Avenue and Keon Street. Contact us at info@qualitydiagnosticlab.com or call 869-465-6657. And yes, si habla español. Quality Diagnostic Laboratory. Excellence in performance.